Good afternoon, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled SAMHSA Women Matter Training Toolbox. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. You may use the Q&A panel to send any questions you may have as you think of them, and the presenter will answer questions at the end of the presentation. Our audio is being broadcast today through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel as well. If you continue to experience a loss of audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen as well to receive a statement of credit. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. Also, a PDF version of this PowerPoint presentation will also be provided to participants within 5 business days. As many of you know, FADA produces many webinars through the support of the Florida Department of Children and Families. To help participants track credits earned through webinar attendance, we have launched a new website that provides a personalized digital journal where participants can maintain statements of credit for every webinar and workshop taken through the Florida Alcohol and Drug Abuse Association. So at the conclusion of today's webinar, as usual, the web browser will direct everyone to an evaluation on the FADA website. You will be prompted to register or log in to complete the evaluation. Once you do register and complete the evaluation, you will be able to access a statement of credit right in your member profile. Keep in mind that any information you provide FADA as part of registering remains confidential. Also, as usual, completing the evaluation is necessary in order to receive CE credits or to access your statement of credit. Approximately 1 continuing education credit will be available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Do note, please, that WebEx monitors arrival and departure of attendees and provides us with a report upon completion of the event. We are not permitted to provide contact hours or a statement of credit if you do not attend the entire webinar, and we are not permitted to provide partial credit. I'd like to introduce our presenter now for today's webinar. Hendrée Jones, Ph.D., is an internationally recognized expert in the development and examination of behavioral and pharmacologic treatments for pregnant women and their children in risky life situations. A professor in the Department of Obstetrics and Gynecology at the School of Medicine, University of North Carolina in Chapel Hill, she also is Executive Director of UNC Horizons, a comprehensive drug treatment program for pregnant and parenting women and their drug-exposed children. Dr. Jones has received continuous funding from the United States National Institutes of Health since 1994 and has published over 175 publications, 2 books on treating substance use disorders, 1 for pregnant and parenting women and the other for a more general population of patients, and numerous books and textbook chapters. Hendrée has been a consultant for the Substance Abuse and Mental Health Administration's Women Matter Toolkit, the United Nations, and the World Health Organization. Dr. Jones leads or is involved in projects focusing on improving the lives of children, women, and families in Afghanistan, the Southern Cone of South America, the Republic of Georgia, South Africa, and the United States. She holds a doctorate in psychology from Virginia Commonwealth University and Medical College of Virginia, and we're very pleased to have Dr. Hendrée Jones join us today. And Hendrée, if you're ready, I'm going to bring up your presentation and turn control over to you.
All right, thank you so much. And can you hear me?
I can hear you just fine.
Perfect, thank you. So thank you to Fata and everyone on the call today for inviting me back to give another webinar. Today we're going to be talking about women and substance use disorders and really focusing on health and wellness, which I often think we don't get enough time to focus on. So I'm very excited about this topic, and I don't have any conflicts of interest that would be related to this topic. And I need to move the slide.
And Hendrée, remember that you'll want to take your mouse and click one time inside the window to activate it.
Yep, and that's what I am.
And then use your page up and page down keys. There we go.
Thank you. Okay. My learning curve is flat when it comes to that. So the learning objectives that we have today are to talk about 4 different life domains that we know are impacted by opioids and well as other substance use disorders, and thinking about those life domains, how they are related to treatment and to recovery, and how we can really help women heal those different life domains. Then we're going to be looking at different ways that traumatic experiences actually shape parenting practices for the women that we work with. And then finally, talking about active components that we see are keys for living a complete whole and well life in recovery. So as we think about this topic, I think it's important to sort of recognize what our national data are telling us. These are data from SAMHSA, where we can see that for all of the data points there, men have higher percentages than women do. So we know that more men on average than women are using substances, including alcohol, and are more likely to be first-time users. So in some ways, it could be seen as being a woman is a protective factor. However, we also know that when women do have substance use disorders, that many times there are many life domains that are more adversely affected than men, things like physical effects, which we'll talk about, as well as mental health. And then these are data looking at pregnant status as well as non-pregnant status among women who are 15 to 44. And if you look at the green bars, those are pregnant women that are coming in for treatment. And if you note in the pale, I guess sort of off-white bars are non-pregnant admissions. And one of the things that I think is interesting about these data that were reported by SAMHSA is that for both any heroin and other types of opioids, more pregnant women are coming in than non-pregnant women. What I think that actually speaks to is sort of the focus on pregnant women and the emphasis that has been placed on getting pregnant women into treatment. Because we certainly know that being pregnant certainly isn't in any way gives you immunity from having an opioid use disorder, and perhaps it actually helps get you treatment. These data, too, I want to give a shout out to our SAMHSA guidance document that just came out last month. It's got a lot of great videos and practical fact sheets that can help guide working with pregnant women and their children that have women that have opioid use disorders and their children that have been prenatally exposed. We also know from a tremendous amount of data that for women, there's a telescoping effect. And so what that really means is that women tend to start using substances on average later than men do. However, the time between their first use and their development of problems is much shorter. It's this telescoping effect that happens. And so that's really important because we want to know if we can't prevent substance use and substance use disorders, we really want to be able, as soon as a woman is disclosing this, to be able to get her assessed and get her into the intervention or treatment that she really needs. When we look and we think about substance use disorders, I often think about it in a 24-hour clock. And when I talk to the women that I work with, they're really focused on sort of 3 aspects. Seeking drugs, they spend a lot of time seeking drugs, they spend time using drugs, and they spend time recovering from drugs. And I think of this almost in sort of 3 panels of gray as in this sort of active, chaotic life of addiction. And when we talk about treatment and we talk about recovery, which are 2 separate processes but can be intertwined processes, we want to think about what is that role that that substance has been playing in the woman's life. How has it impacted her health? And when I say health, I mean like her body health, her physical health, her brain health, her mental health, and that emotional wellness that is so important for not using substances and living a life in recovery. Thinking about purpose, as I said, thinking about that 24-hour clock, what is the greater purpose that she can engage in meaningful daily activities and being independent and having her own resources? How is she connected with community? When you're in active addiction, many of the women I've talked to just talk about how incredibly lonely and alone they are. You can be in the midst of using drugs with many different people, but it's an incredibly isolating and lonely endeavor. And so getting women re-established with them, relationships with themselves, as well as, a higher power, if that's something that is a part of their treatment and recovery, and then with community and family and friends. And then finally, the home piece. And certainly I've seen throughout the 2 decades that I've worked with women and children, the need for stable housing is such a help for when you have that stable housing. It can be so helpful for promoting health, wellness, and recovery, and it can be, without it, such a difficult barrier for women to get well and to stay well. In terms of the physical effects of alcohol and other drugs that we see, as I had said earlier, the physical effects of substances can actually be much worse for women than it is for men. We see this particularly with alcohol. We know that women use less alcohol than men do, but can have more damaging physical effects in terms of liver effects, heart effects. The way they process alcohol, metabolize alcohol is different. And there's also some data looking at cocaine and even showing that depending on where you are in the menstrual cycle, that can be a more or less of a risk factor for relapse to cocaine use. So we know that all substances that are entering the body are stressors for that body, and thinking about the role that they're playing in the immune function, blocking sorts of vitamins and minerals, and just what do we need to do in treatment to help get women back into physical health is really important. There's another slide just looking at the alcohol. We know certainly, while there's been so much attention that's been given to opiates, that alcohol is still the most common substance that's used in the United States, along with tobacco. and we know that women can have many more health complications, and the cognitive impairment that can happen with alcohol. And we're even seeing sort of early cognitive problems for people that have been drinking for many years, and women can be more susceptible to this than are men. One of the things that we look at when women come into my treatment program are the variety of chronic health conditions, making sure that women have access to a primary care provider or some other type of physician that can do a health assessment of the history and physical on them is really important, because we know, for example, even with dental issues, that if you have untreated dental issues, you can be in a lot of pain. That can be a risk factor for relapse. Or for not being able to stop substance use. We know that women that have used substances chronically have more autoimmune problems. Certainly, they can be at risk for sexually transmitted infections. They can have thyroid issues, asthma, the other types of cardiovascular disease. Untreated pain can also be, it's a very tricky issue to disentangle, particularly the opioid use disorder from opioids being prescribed for legitimate pain purposes. So there are many different, both acute as well as chronic conditions that we want to think about that can have lasting impacts for women's being able to get proper treatment for their substance use disorder and to also stay in recovery. It's really hard to maintain recovery when you have a lot of unmet physical health needs that are creating impediments into being able to live a full life. Women are also have increased vulnerability to co-occurring psychiatric disorders compared to men. We have several data sets that would show that. We know that women often report using medication or substances to self-medicate anxiety and depression, and certainly trauma. And we know that there's also commonalities between having a substance use disorder and an eating disorder like anorexia or bulimia or even binge eating disorder. And that, of course, can also be intertwined with violence victimization and post-traumatic stress disorder. And there's been some really nice work looking at how to not treat PTSD, post-traumatic stress disorder, in isolation or in parallel, but really integrating it with substance use disorder treatment. Certainly Lisa Najavitz and Seeking Safety has done a lot of work in that area. And I would refer you to her work and published manuals on that. In terms of depression and substance use disorders and women, we estimate that particularly with women that have opioid use disorders, that almost 50% of women may have co-occurring depression sometime in their life. We know that there are high rates of injection drug use that occur with just adults in general that have opioid use disorder and depression. And there's oftentimes those co-occurring disorders go untreated or undertreated because there is such a focus on the opioid use disorder, and the mental health, the co-occurring mental health issues aren't addressed, and so that can, again, be an impediment for helping women obtain and remain in recovery. So we really need to be looking at integrated treatments and helping them. Suicide, I think this is one of the most striking issues and concerning issues that we have. I've looked at data over the past 20 years of women coming in either to the Center for Addiction and Pregnancy at Johns Hopkins University or in my center at Horizons at UNC Chapel Hill, and it's remained incredibly, unfortunately, stable that about a third of the women that come through that are looking for treatment while they're pregnant and parenting have attempted suicide in their lifetime. And so I think that this is something that definitely deserves serious attention to make sure that as you are doing screenings and intakes and assessments for women that we're asking about the suicide in terms of thoughts and perhaps past actions, and if they are endorsing that we have a protocol to be able to assertively and very carefully be able to determine how likely they are to be acting on that, and then to be able to get them the help that they need. And then intimate relationships. For many of the women that I work with are engaged in intimate relationships, and we know that there's often a high rate of substance use among the couple. And this can be heterosexual as well as homosexual couples that are both engaging in substance use or both having substance use disorders and engaging in substance use behavior. And it's very important to be able to understand the role of the relationships that the women have. Sometimes they're very complex relationships. Sometimes we have women that have more than one partner, and multiple partners have substance use disorders, and so anything that we can do to help get the partners into treatment can also help women stay in treatment and remain engaged in treatment and help to enter the recovery process. Because we've done a couple of studies looking at when the partner relapses, that the woman is much more at risk for relapsing to substance use. So taking that partner and not isolating them or saying that, you know, we can't do anything with them, the women aren't allowed to see them, because we know that the women are more likely to break up with treatment before they are likely to break up with this partner that has a lot of power and control over them. So taking that opposite approach and figuring out how we can get them into treatment is something that's been successful for us. The effects of interpersonal violence really I don't think can be overstated. One of the interesting topics for research now is looking at traumatic brain injury, and I do a group every Tuesday for the women at Horizons, and I'll often ask them with a raise of hands how many of them have ever been hit in the head and passed out, been in an auto accident, you know, seen stars, had concussions, or had physical violence that has resulted in harm to the head. And very much routinely, about 80% of the women in group will put up their hands saying that that's something that's happened to them. We know on average in the general treatment population, about 40% of patients have a diagnosed traumatic brain injury. And why that's important is that they're learning differences that can happen with traumatic brain injury. So using different types of learning techniques can be really helpful for women as well as men to remember the behavioral tools that we're giving them, to remember what we're talking about. So things like chunking information, repeating information, and using different senses like hearing and seeing and actual touch for different types of interventions that we can really help them remember what we're trying to tell them. And then, of course, you can see on this slide all of the other effects of interpersonal violence for women reporting more chronic pain, hypertension. Obviously, there could be at risk for pregnancy problems if they're pregnant. Certainly the social withdrawal, isolation, and fear that they feel, and then being at increased risk for anxiety, depression, and suicide. This is one of my very favorite tools for screening for interpersonal violence because it's so short and because it is so sensitive. So really there's just these two questions that have been very accurate in classifying victims of domestic violence or interpersonal violence, as you can see on that slide. And those two questions are, in general, how would you describe your relationship? And if the women say a lot of tension, then that is a red flag. And if they also respond with the answer of great difficulty to the question of, do you and your partner work out arguments with great difficulty, those two are very important red flags, and then that should facilitate, they've screened positive for interpersonal violence, and so then thinking about what kind of assessment is needed, what do we need to do to listen to her and believe her story, to validate her and acknowledge that she doesn't have to be alone with this type of abuse, and that what resources can we help give her so that she can get some assistance and help that she needs. And certainly we know that when we're talking about women who have children, there are a tremendous number of complex issues that both the women and the children come to treatment with, or the children, if they aren't specifically getting treatment, they're still involved with women that are being treated. And so I've broken those into specific issues for mother, for the dyad, that mother-child relationship, and then the child themselves. And I think oftentimes when we get women into treatment, we are so focused on that substance use disorder that we forget about the dyad, that space between mother and child, and how important that is to helping to break the cycle of addiction and to really being can be a source of support and healing for both the mother and the child. So how do we help women heal in those 4 domains? We've talked about how substance use disorders can have an impact on these 4 domains. And so, thinking about what are those aspects of health that are important to the woman, how do we put those on the treatment plan, getting her obviously a history and physical, getting her hooked up with dental care, getting mental health screening and assessment, and talking to her about what emotional well-being looks like and what are those coping mechanisms and those tools that we can help give to her so that when she leaves the treatment environment, she's got those in her treatment and recovery toolbox to be able to rely on them so she doesn't have to use the only coping mechanism that she's known of that substance use disorder. Dialectical behavioral therapy skills, I can't say enough about those. They're some of the women I work with are the most popular skills and the most useful skills that they have, and I think can really go a long way to helping women maintain that emotional well-being. In terms of purpose, what are we doing in terms of the treatment plan or in terms of case management to really help them fill out an interest inventory, get back engaged in creating a resume or applying for jobs? What do they need to do around explaining criminal activity, perhaps, or other complicated legal things that they might have on their record? So what can they do within their means to be able to have engaging, meaningful daily activities that can help bring them a sense of purpose that's higher than themselves? Thinking about community, relying on recovery supports in the community, NA or AA meetings, or Celebrate Recovery or Rational Recovery, getting a sponsor. How are those relationships even within the treatment program that can be sources of support, love, and friendship? And what does she need to do to heal the relationship with herself? Many of the women that I work with say, I don't even trust myself. And learning how they can trust themselves first and then start to look outward to nurture relationships with other people can be a really powerful source of the treatment process and entering into the recovery process. And then, of course, for us, it's the biggest barrier is that housing stability and where is that safe place to live. So knowing the resources in the community to be able to get HUD vouchers or other types of housing supports, Oxford House or other types of things, again, is such an important aspect of helping women heal. So linking and integrating, this probably goes without saying that communication absolutely is the key, and I know it can be incredibly frustrating because you're in a treatment program. Oftentimes, the fee-for-service or other billing aspects of what we do really doesn't reimburse for that connective tissue of what I think makes treatment work, which is communication. So having really good communication with child protective service workers, having good communication with judges or other folks in the legal system or police or school systems, medical providers, any of those people that are going to be interacting with the women with whom we work, we need to know who they are and how we can best communicate with them. We found, obviously warm hands-offs are much better and much more effective than just a piece of paper with a name and a number. And then making sure that we're documenting our referrals. Where are we sending women? How did that work out for them? Circling back around with them, how was it? Did you have trouble getting there? What was it like? How were you received? What was the outcome? Were they helpful? Were they not helpful? And then I know if we don't talk to our women about literally walking them through, how are you going to get to that service? Which bus are you going to take, or where are you going to get transportation? Having her practice what questions she's going to be asking to that other provider that you're referring to, and then how she's going to get home. All of those things are simple, but I recognize they take a lot of time, but it can really help empower the woman to be able to do it on her own next time, as well as make your work much more successful because she's actually getting to those services that she needs. And certainly peer support specialists or recovery coaches, again, I think are the connective tissue for treatment, and I think they're such an integral and important part of our team team because they have that lived experience to be able to help our women navigate through the different systems that they need to navigate through. So collaboration, one of the things that we do is we regularly meet as a team about every 6 months, because all of our team members know different resources in the community. And so we take a little bit of time, meet as a group, bring all of our resources together, and it's amazing what new resources have popped up or what resources have gone away, and these different sort of aspects of services, little pockets in the community that are doing really great things. And then we keep them in a centralized database that can be updated. And knowing the specific names of people in those partner organizations, and just maybe a little bit of a note about them, because we do have people that rotate through loss and attrition of providers, and so having all of those notes in there can make that transition really smooth, so we don't have to start over from scratch building those relationships. The University of Vermont has a wonderful toolkit which is really specific to buprenorphine. It's called the CHARM Collaborative, and they have some great examples of memorandums of agreement or understanding where they can have exchanges or releases of information among many different system providers that can be a huge help to our women and children when they need different services. And then, really taking the time to talk with the patients about what was that experience like with whatever referral place where they were sent. Was it positive? Was it negative? What can we do better? What kind of feedback can we give to that provider that was providing care? All of those things can just make the treatment experience better for the women, and also make your job easier in the long run, because you know much more about what's happening in the community and which places are going to be helpful or potentially hurtful to the women that you work with. So just in terms of learning objective one, we've talked about different ways that we can practically help women with their physical health, thinking about ways to help them engage in purpose, thinking about the home front, and even if they can't move out, what are the different things that they can do to make that a more livable environment for themselves. We can't change often the environment, but we can change the way we respond to the environment. And so thinking about practical skills and tools that can help them do that. And then finally, being engaged in community. I think, it's been said on a TED Talk, the opposite of addiction is connection. And I think connection with self, with others, and with a larger community can be such a source of resilience for our women and the children that we work with. In terms of turning to the next learning objective, we had to identify several ways that past traumatic experiences can shape parenting for women that have opioid use disorders or other substance use disorders. And so I think, understanding how the women themselves were parented is a critical piece to really being able to help moms become the best parent that they can be when they're working with their children. A big piece of that, of course, is understanding attachment and how the women were attached as children. Attachment theory, of course, has been around for many, many decades, first started by John Bowlby, who was raised by his own nurse and very much sort of ignored by his parents. And he went on to do a lot of studies looking at maladjusted or delinquent children. Mary Ainsworth picked up on that work, and then you've probably heard of the strange situation procedure, where she started to classify different types of responses between mothers and children into different types of attachment styles. And really the attachment style that we find to be the most positive and resilient for children is when they feel safe and secure, and that there's a predictability to the caregiver consistently being happy to see that child and also happy to release them into the world and then to come back. And that's what we know the most about in terms of positive emotional development as well as cognitive and social development. And so understanding how women were parented, what it was like. Many of our women have been through multiple foster care placements or have experienced a tremendous amount of adverse child experiences. And there's a thought that the insecure attachment that they felt as children, you know, there's an effort to cover up that psychological pain or discomfort or numb it in some way, and that perhaps that insecure attachment can really be a risk factor for later substance use disorder. And so thinking about that and wanting to break that cycle for the future generation can be an important part for looking at how we work with women and children and what kind of internal working models did the women develop when they were children. Did they learn that the world is a very scary and unpredictable place, or did they learn that the world is a secure and predictable place? And understanding where they're coming from then can help them shape how they're going to do their parenting practices in the future. So this just talks more about the secure attachment, and when we have secure attachment, we know that there's predictability. So I know that if I'm scared or if I'm hurt, I can go to that caregiver and they're going to reliably and predictably receive me, and I'm going to be comforted. Children that live in maladapted or insecure attachment, they don't know. There's an unpredictability and not knowing if that caregiver is going to be available or not, or how they're going to respond. And so there's nice work to look at the stress activation system, and that children do have sort of changed HPA axes and are responding to stress in a different way. And so what can we do when we have those types of interactions to sort of help the caregiver increase their predictability and their nurturing, so we can reduce the detrimental effects of that chronic stress that children might be under. And of course, growing up in a home where there's active substance use and substance use disorders, we know, of course, that is associated with a high risk for child abuse and neglect, and we want to be able to do everything we can to help mitigate that. Where there's also work looking at moms who have substance use disorders often have more negative or hostile attributions to their children. I used to see that at the Center for Addiction and Pregnancy, where even during the fetal monitoring, women, if they found out a certain sex of the child, had very negative opinions about it, with one woman even saying, you know, it's a boy, it's going to be just as greedy and good for nothing as his father. So what can we do to say, wow, let's think about a different way that we can have attributions for those children, and then giving moms or caregivers more appropriate expectations of children's behavior. What are the developmental milestones? When should we be expecting potty training, sleeping through the night, taking in different types of foods, and so on and so forth, and really helping them understand the difference between discipline and punishment, because many of our women only grew up with pretty severe physical punishment. And so if that's the only tool they have in the toolbox, that's what they're going to use. So exposing them to different types of models and different types of behaviors to help them raise healthier and more well-adjusted children is always our goal. Bruce Perry and his colleagues have done some really important work looking at trauma and the brain, and we know in brain development that the brain sort of starts at the brain stem, and then as we grow and develop, the cortex, so the top part of the brain, is really the last to develop and mature. And we know that in severe abused and neglected children, that the proportions of brain structure is actually a bit different than from non-abused and neglected children. And it's that midbrain where, you know, a lot of our emotions and fear, survival kind of mode becomes much more developed, and the other parts of the brain haven't developed as much. And so thinking about how drugs even act on the brain with the amygdala and the hippocampus and other brain parts, you can see how being a traumatized child can predispose you and put you at risk for using substances and even having a substance use disorder. So it's something, recognizing that children do have very plastic brains, which is good news. We want to be able, as early as we can, to obviously reduce and prevent that trauma to help support healthy brain development. And there are some great evidence-based tools that support that healthy attachment and hopefully healthy brain maturity. And so those different tools, these are examples of tools that we've used at UNC Horizons. The Circle of Security Parenting, there's a national one and an international one. It is copyrighted and you do have to pay for training. But it really talks about, you can see that the graph at the bottom, the Circle of Security, it talks about having a secure base and children being able to explore, and entrances and exits for children. And parents often naturally feel more comfortable with, sort of sending their child out into the world or receiving them back. And so it becomes the sort of what becomes more natural for them, and what do we need to do to strengthen both sides of the healthy release and healthy return. So the entrances and exits, and understanding how the parents were parented and helping them realize what their triggers are for potential maltreatment. To help with a better dyadic relationship. In terms of the Nurturing Parenting Program, that has a larger age range. There's a lot of skills that are gone over, and depending on the age and stage and development of the child, it's very parent involved, obviously. Hug Your Baby is another one that focuses on appropriate developmental milestones, very specific behaviors for understanding signs and cues of the baby, baby's crying superpower, that sort of thing, swaddling, soothing, and helping empower the caregiver to understand baby's cues and read them and respond to them. And then child-parent psychotherapy is an incredibly detailed and very intense psychotherapy that requires a lot of training, but if you have someone in your area that is trained and skilled in it, it can be a huge asset to helping both moms and children. And then finally, the Triple P, Positive Parenting Program, again, that has, it's available for both children as well as teenagers, and it really is to both prevent those behavioral and emotional problems, as well as designed as an intervention to help treat children that already have behavioral and emotional problems. And again, working very closely with the caregiver and helping to support them and give them skills to be able to better understand and respond to the needs of children and what the children are trying to tell them. These are just some of the outcomes that we have from UNC Horizons looking at parenting stress. When our women come into treatment, they have a huge amount of parenting stress. And with that intervention and over time and even post-treatment, we've been able to show that they can reduce their parenting stress. They feel more confident and competent about their parenting practices, and they use less punitive and punishing practices and more disciplined practices. To help their children. They understand more about the nature of being predictable and the need that children have for repetition as well as routine. And then you can see for our residential services, many of our women, the vast majority of our women have positive cases closed with children regaining custody and cases closed if they've come in with an active Child Protective Service case. And then for women in our outpatient setting, this is about 5 years in a row, we've had 75% of our families that have had positive changes. So this attachment-based parenting, we believe, is an important component of our overall treatment program to be able to have the outcomes that you can see on that slide. And I think we oftentimes get really focused on just the treatment and forget or often don't have the resources that we need to be able to continue to have that continuing care, aftercare, or recovery support services. But within our means and our ability to do so, we need to make sure that women are getting and families are getting what they need to help address for the entire family what are healthy relationships, how do we continue those positive parenting practices so that women continue to be able to parent, practice those parenting skills, where do they go when they need help or they get stressed or they've had a crisis. So what else do they need in terms of those recovery supports for their health? A lot of times for pregnant women, they come in and 6 weeks postpartum, they're discharged, and there isn't that warm handoff or linkage to continuing those family services. So thinking about what's in your area and making the most of what's in your area will be such a value to the families that you work with. And so that brings us to the end of our second learning objective. So we want to make sure that to be able to break that cycle of abuse and addiction, that we recognize that many of our women have been maltreated in their childhood, that we're giving them the tools that they need to understand how they were parented and how they want to be able to parent, to have their children be able to be nurtured and to thrive moving forward. We want to be able to use the best evidence-based parenting programs within our means. I know that the ones I presented to you all have a cost, but thinking about that in terms of an investment on the return of the lives of our families, I think that that doesn't have a price, and that we need to do a better job of using those as evidence-based parenting programs. And then just continuing to recognize where we can that the positive attachment and the radiating effects that it can have, not just for mom and children, but for future generations of their children's children. So now let me turn with the time that I have to recovery. And I've mentioned recovery a bunch of times without defining it. And so the way SAMHSA has defined recovery is a process of change where individuals are improving not only their health and wellness, but they're living that self-directed life and doing everything they can to reach their full potential. Sometimes treatment and recovery are used interchangeably, and I think that they are two different and yet can be intertwined processes. So I see treatment as sort of the set of tools that we need to help get people onto the right track for living a healthy and purposeful life, and recovery is that process or that journey to continue that for the rest of our life. Just as we saw before in terms of what are those domains that substance use disorders have affected, these are the same domains that we need to be looking at for supporting recovery. So making sure when women leave treatment or getting ready to leave treatment that they have ways of self-managing different illnesses that they have, or that they have outside support that they need to be able to address issues as soon as they come up, or prevent issues. The preventive medicine is super important. Being able to have the tools that they need to make healthy choices in terms of nutrition, in terms of exercise, and what they need to do to ensure that they are more emotionally stable and have emotional well-being. The home, we've already talked about, and there are many sober living homes, and there are other types of supports that are out there to provide healthy drug-free living, and knowing what those are in the community can be really helpful. Having that purpose, the higher than themselves, getting employed, or if they are on disability in some ways, just volunteering, giving back to someone and giving back to the community can be such a source of pride and reinforcement and engagement for our women. And then finally, that community piece of finding the ability to forgive themselves and others, and to love themselves, and then trust themselves to be able to have a good relationship with themselves, with their children, and with their community. Who are those social supports that are positive for them, and eliminating or reducing the interaction with those unhealthy supports. When we talk to women about recovery and listen to the recovery stories that they tell, there are often 10 components that come up as themes. So self-direction, you can't live somebody else's recovery, that it really needs to be from within and tailored to the individual as to what makes sense for her. It needs to be person-centered, so that she is the one that is directing it, that's guiding it, and it's really about her. And obviously that is intertwined with empowerment. Many times I hear the women that I work with talk about how they found their voice, how they're using their voice, how they feel more empowered today than they ever felt in their life, how they feel like they don't need the man or their partner that they've been relying on and depending on. They found this sort of sense of empowerment and fulfillment, that recovery is more than just not using drugs. There's a difference between just being drug abstinent and being truly in recovery. And that recovery piece is holistic. It's those 4 dimensions that we talked about. And that it also, while relapse doesn't have to be always a part of recovery, it is a common part. And so there isn't always necessarily a straight line from active addiction into complete recovery for the rest of your life, that there can be a winding road, but it's how to learn very quickly if there is a lapse or relapse, how to get on top of it and get back on the road to recovery. Many of the women that I've also worked with talk about how thankful they are to be in a strengths-based program. Many other programs have looked at everything that they're not doing, and it's very negative or deficit-focused, and how having the strengths and seeing themselves as resilient, as survivors, as resourceful is such a powerful feeling for them to help them resolve or come to an understanding and move through the sadness, the shame, and the guilt that they felt, to be able to be in a much more positive place so that their own self is filled up and they can give back to their children and to other people. The peer support obviously has been shown many times to be an important part of recovery ever since the founding of the recovery efforts around the world. Respect in terms of respect for self, respect for others, respect for the environment, respect for small things. There's a piece of gratitude in that respect and never taking anything for granted that I often hear as an important component of recovery. Responsibility, which again comes down to that sort of self-direction. You are your recovery. You have to put your recovery first. And then recovery emerges from that hope that I'm sick and tired of being sick and tired, and I'm going to do something different, and I'm going to be hopeful, and I believe that there is a better way, and that there's a rainbow or a sparkly tomorrow. Again, are themes that help, I think, women talk about recovery and are parts of helping them maintain that recovery. The language of recovery, there's been a lot of published literature on this recently, and so thinking about how we as professionals talk about treatment, talk about the women that we work with, the children that we work with, and so I would encourage you to kind of look through this slide. I'm not going to read it to you. I will point out 2 or 3 things that I think are really important. So if substance use disorders are a medical disease or a medical illness for which there is treatment, which is my belief and understanding, then we need to use the language that honors it as such. And so don't use the word dirty urine or clean urine. I think that's got a very negative, prejudicial stigma on it. And so using more medicalized language such as a positive urine or a negative urine really affirms and supports the idea that substance use disorders are a medical illness from which there can be treatment that can happen. And another piece that we talk about in terms of health and wellness and recovery is control. Understanding that there are many things in life we can't control, but what are the things that we can control? We can control making healthy choices. We can control aspects of our living circumstances, maybe not all of them. Excuse me, I have to cough. What is it that we can do to help manage our stress level? Stress really comes from feeling that we can't predict or have control over things in our lives, but there are always pieces that we can control, and we can control our response, how we respond to things. Making choices about recreational activities, thinking about purposeful living and practicing those, even small aspects of it. What are we doing around employment? What are the very small steps even that we can take towards employment? Thinking about health and nutrition, exercise, sleep. What are we doing to support healthy sleep hygiene? Having those positive social supports. How are we engaging in community? And then, of course, relationships and being able to feel empowered to make healthy relationships and make changes in the relationships that we have to get us on a more positive footing. So we see recovery, as we said, as a lifelong process. That is inextricably linked with growth and learning as a human being, hope, experience, and the continual process of healing. So we can't just see recovery as not using substances. We have to see it integrated into all aspects of life. SAMHSA talked a lot about dimensions and domains of recovery, and just thinking about how the 8 SAMHSA dimensions really map onto our 4 domains of how substance use disorders impact our life. So what do we need to do to be emotionally well, emotionally stable? And if we become unstable, what is it that we need to do to help understand and recognize what those emotional triggers are and what we need to do to get ourselves back on an even keel? What are those environmental triggers that we have that can, even before we ever pick up a substance, can lead to stinking thinking or other types of red flag behaviors that might lead us to set us up for relapse? What do we need to do to get our financial house in order so that we feel more economically independent or secure? What do we need to do intellectually to keep ourselves learning and stimulated? We learn until we die. So what is that keeps us intellectually curious? In terms of occupational, which kind of goes with what we have we talk to our women about just now jobs and future jobs, and sometimes we have to have a just now job to get to the future job. But what is our occupational pathway? Where is it that we want to go? What are the goals that we have for ourselves? Again, that ties back into the hope for the future. And we've talked about the physical wellness in terms of both brain wellness and other body parts for physical wellness. That social piece for being connected with positive drug-free social supports, and then the spiritual aspect, asking, not being afraid to ask about spirituality and how that's connected to recovery, and also if women have had negative experiences in growing up with spirituality or religions, and understanding what they need to do to heal from that, and what role that needs to be playing in the future or not. So we want to engage women in wellness, and I talk a lot to the women about, everyone walks through life looking through certain lenses, and as we go through life, those lenses are shaped in different ways, just like with the attachment theory that we talked about early. You get sort of these early lenses that shape the world as being safe and secure or more scary and unpredictable. And we often are what we focus on. And so if you were to come to UNC Horizons, you're going to see every group I do, I start with gratitude, because we have to start with what's working right in our life. What are the positive strengths that we have? What are we grateful for? Every single person on the face of this earth can be grateful for something. And so helping our women focus more on what's working right, what they have, rather than what they don't have, I see as an important part of engaging in the recovery process. There's been data to show that, or data reports that, the external world, so going shopping and having material goods, only predicts 10% of your happiness. So the 90% really can come from your internal world. And so helping women not focus on so much the external, but focusing more on the internal and what they can do to self-soothe and feel more comfortable and confident in their own skin can be an important part of that healing process. And talking to the women, too, about, it's not just enough to be drug-free or in remission from a substance use disorder. That doesn't necessarily mean that you're healthy. So what does whole health mean? Making good food decisions, drinking enough water, refraining from caffeine or energy drinks, getting exercise, getting proper sleep. So what goes into health? That can help create real wellness. And seeing that happiness isn't necessarily a destination. Happiness is something that's internal, that we create, and that we talk about positive brain changes that can happen from really focusing on gratitude, focusing on meditation, focusing on mindfulness, and being more present in the moment, and can help sort of alleviate or sort of start to address some of that anxiety and the guilt and the shame. And then giving them practical tools for how to actually rewire the brain for gratitude and happiness. And so this is one of the things that we've adapted in terms of giving women journals and practicing each day, writing down new things that they're grateful for. And we give them it as a gratitude journal, and they make it pretty and they decorate it, and they write down experiences that have happened to them or things that they're grateful for. They also will set gratitude goals for things that they want to do. We give them time to practice meditation and mindfulness and ask them to do nice things for others. And it's amazing to watch the changes that happen to our women as they go through our residential treatment program or our outpatient treatment program, and they start to sort of internalize the language, and they start to spontaneously say, you know, I am enough. I am grateful for this, and it becomes much easier with practice. And then they can start to focus on what's going right. We certainly know that health and wellness in recovery is an individual process. It's nothing that we can force on anybody. They are totally in control of that. But we can use the gratitude and the wellness as a way for them to feel more in control. And then it gives them the resilience to overcome some of the negative experiences that they're going to encounter in their daily life. But they have better tools in their toolbox to be able to respond rather than to react in negative and less helpful ways. Focusing on the positive in terms of health and wellness and recovery, thinking about, again, not just being healthy, but how can we help them be above normal? How can we help them feel more mature? How can we help women feel that they have well-being and express that well-being? And we know there's wonderful group work even to show that the more affiliation statements that women are saying in group, it's a huge predictor that they will remain drug abstinent later after they leave group. So what are those things that can help them feel more connected, to help them feel more resilient, to help them feel like I have the tools that I need to be able to encounter the challenges that I'm going to have in the future? And ideally, we want a recovery-oriented system of care. I'm really impressed with Michigan actually has a whole division now of a recovery-oriented system of care. And thinking about this, you know, it's not one person's job, it's everyone's job to have a recovery-oriented system of care, and how wonderful it would be if the recovery-oriented system of care supported not only that woman, but the family as well as the community, so that she's getting regular checkups to see how she's doing in all aspects of her recovery, not just drug abstinence. How's she doing in her parenting? Where can she go to receive the support that she needs when she runs into trouble? How do those systems work together in terms of family child care systems, in terms of housing and transportation, those spiritual services, healthcare services? How do they work together, not in isolation, but actually in a connective web to be able to really support her? And the Vermont Charm Collaborative, I think, is taking very nice forward steps into developing that system. There's another model in Dartmouth that is also working on setting up this sort of more hub and spoke model to create that system of care where individuals, community, and larger society and governments and even businesses all have a role in the recovery-oriented system of care, and how we can help keep people well and not wait until they're far down the road of relapse before we start to intervene, and then we end up intervening in the exact same ways each time. So we've talked about a number of active components that are keys that have been identified by SAMHSA for living in a whole health and wellness during recovery. We've talked about, you know, the 4 domains of the home and community and purpose and health. We've talked about the 8 dimensions that I just showed you, and then those 10 components of recovery. And I think, you know, again, it goes down to feeling connected, inspired, and grateful and nourished for being alive. So the take-home messages from the webinar today is to hopefully have given you some hope that substance use disorders are treatable illnesses, that women can get into a sustained life of recovery, and working the dimensions and the domains of recovery can be very helpful components for her success. That we can't just focus on the drug use in isolation or just focus maybe just on parenting. We really have to understand the whole person. We have to understand the child, and we have to understand that relationship between the mother and the child for how to help promote that resilience. And there's some great parenting practices, evidence-based practices that can help our providers help the families that we work with. and that wellness and recovery are possible, and there are millions of people that are out there that have that lived experience that can be part of this whole recovery-oriented system of care. And with that, I will stop, and I'm happy to answer questions.
And Hendrée, thank you so much for that. I'm going to go ahead and move into some technical information for our participants. And I'll also keep an eye on the chat panel and the Q&A to see if we have any questions come in during this time. But thank you for a very comprehensive treatment of the topic. I appreciate it. And let me just check on something right quick. Okay, so for all of our participants, Hendrée, I'm going to go ahead and take control of the presentation back, if that's all right. For all of our participants today, do be aware that when I do conclude today's webinar, your browser is going to take you to an evaluation on FATA's new website. And if you want to receive CE credits or a statement of credit for this event, please do complete the evaluation. You will be prompted to register or log in to complete the evaluation, and you can register as a visitor. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number at least the first time you register. After you register, you will be directed onward to the evaluation. After you complete and submit the evaluation, you will immediately see further guidance to access your statement of credit within your new member profile. You will get a second opportunity to complete the evaluation through a follow-up email later today, and you should receive that in about 30 minutes. And on screen right now, that's the who the email will come from. That's the from address on screen right now. And Hendrée, we do have one question. I'll go ahead and read that to you if you're ready.
Sure. Yep, that's fine.
Okay. It says, I was wondering what information you have regarding long-term impacts of methadone treatment on children exposed prenatally and as newborns through legal methadone programs.
Yes, so I am so glad someone asked that. Thank you, Heather, for asking that. We literally just published in Drug and Alcohol Dependence this month a paper looking at comparing babies that were born prenatally exposed to methadone while in a comprehensive treatment program, comparing that to babies that were born prenatally exposed to buprenorphine, and then also looking at norms in terms of physical, behavioral, cognitive indices up to 36 months. And what those data show is that the children either prenatally exposed to buprenorphine or methadone are very similar. They're similar to the norms. They're on the low end of the norms, but they're still within norms of tests. And so in terms of cognition, in terms of development, in terms of behavior. So we can at least, I feel confident with those data because it was all blinded. And so I think that we have emerging good data to support that prenatal exposure to medications that are treating opioid use disorder aren't having negative or deleterious consequences. Now that said, there certainly are other data out there depending on which country you're looking at and depending on the comparison group that you're looking at that will show less positive changes with children. I think the problem, I think you have to be very careful when you're looking at those data, because if you were comparing, for example, a low socioeconomic status population with a high socioeconomic status population that had exposure to good nutrition, less rates of violence and victimization, less rates of depression, better prenatal care, there are many, many confounding issues that don't allow us to say it's the prenatal exposure to the medication that are driving any kind of negative outcomes for the children. The other piece, too, is the postnatal environment. We've known since the 1970s, and it's been reaffirmed in multiple studies, that the postnatal environment makes such a difference in terms of child risk or resilience. So just, I guess sort of user beware in terms of looking at the data, and that's why I'm really proud of the data that we just published, because we did everything we could to have, a matched comparison to be able to make the most fair and accurate assessment of the children's development and growth.
Hendrée, thank you so much, and we have one other question. It's in the chat panel. How can we access best practices in person-centered recovery programs?
Oh, yeah. That is a really good question. So, I mean, I would definitely look at the resources that SAMHSA has, because there can be some nice documents there. There are also a number of other national recovery programs. You could look at you could also look at Faces and Voices of Recovery. I know they do a lot of advocacy on behalf of helping to understand substance use disorders as a medical illness, and then really focused on the recovery piece. So that can be another source. And I can also tell you that in development right now, our U.S. State Department is actually developing a course for professionals to help better incorporate recovery aspects into their practices. That's in development right now. It's not out yet. I think it'll probably take a year before that gets out, but I would encourage people to be on the lookout for that, because I think that's got a lot of the preview I've seen of it. It's got a lot of really nice practical tips and skills.
Hendrée, thank you so much, and thank you, too, for taking time and sharing your expertise with us today in the broader community. We very much appreciate it.
Oh, thank you for the opportunity, and I hope everybody has a good afternoon.
Wonderful, and let me say thank you to all of the participants in today's webinar. We always appreciate your interest, and finally, I'd like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So everyone, have a great rest of your day, and please hold now for the evaluation. Thank you, and bye-bye.
Bye.